Graham, you're always the first one.
Yep, morning.
Hi.
I don't like to be late.
That's good. So do you guys have Christmas Eve off?
No, well, I'm at the VA, but I don't think even at OHSU they do. I'm on call for Christmas week though, so I don't have anything off.
That's too bad.
Yeah, I got to do it. Second years do the holiday call.
So did you catch on to the theme for these four cases?
Apparently not, because I didn't think there was a theme.
Yeah, it's subtle. Yeah, it's subtle.
Looking
They're all
forward to
Mets.
it. They're all Mets. Yeah, okay. The first one I thought was a Met. The second one, let's see. Yeah, I didn't know about the second one, but third
Well, even
one.
the third with the kidney.
So third with kidney, yeah, I mean, didn't didn't immediately think it was kidney.
Yeah, it's a super rare presentation.
Hmm.
Hi, Chloe.
Hey, good morning.
Hi. All right. It's just the three of us. Let me get started. Um, oh, let me share my screen. Okay, so this first case is a 61-year-old woman. She had a history of anal squamous cell, had surgery and radiation, now with diffuse abdominal pain for 4 days. The CT scan of the abdomen and pelvis showed a 7 centimeter right adrenal mass, no other abdominal pathology. So they did a biopsy, and then that's what I sent you pictures of. Okay. So, adrenal gland, what's the number one, um, what's the most common tumor of the adrenal gland? It's benign. Graham.
Adenoma.
Yeah, exactly. So, when I get these cases, especially, core biopsies where I'm dealing with a small amount of tissue, I kind of go in with my pre-analytical opinion of what it should be, because a lot of times, adenomas can look very different ways. And um, when I know that something is by far the most common tumor, I always think, okay, if I see something unusual, it's probably an unusual variant of the common tumor. And so, but this doesn't look anything like an adrenal cortical adenoma. It's also pretty big. They can definitely be that size. When they get up to around 8 centimeters, you think about adrenal cortical carcinoma. This could be an adrenal cortical carcinoma, I guess, but I don't think so. You usually don't have this kind of what looks like a glandular or micropapillary architecture. So the second most common tumor of an adrenal gland is actually a MET, and then METs can be, obviously from any different area. Adrenal gland is often lung, kidney, breast, melanoma. This looks a little too has too much of an architecture to be melanoma. When I first got this, this is a woman. It does not look like her squamous cell. You can get kind of an acantholytic glandular looking squamous cell. This doesn't look like that. And they usually don't get that in the anus. A lot of those HPV positive ones are more what they used to call cloacogenic. Um, but now they're just kind of basaloid squamous cells. So I was thinking that, this looked like it could be a MET. And it's definitely malignant, a lot of mitotic activity, hyperchromatic. Again, doesn't look like melanoma. It's too much of like a glandular architecture. I was actually worried, and would be a little bit of an unusual site with no other abdominal pathology, but GYN, this kind of looks like a serous carcinoma. It almost looks like they talk about the Medusa's head with the micropapillary borderline tumors that are now kind of classified as low-grade carcinomas. And so that's actually what I kind of favored. But again, it's unusual for ovary to go to the adrenal gland without having like carcinomatosis or anything else. So here's CK7. Yeah, I always do 7 and 20. A lot of times it's not that useful, but if it's strongly positive, at least you're pretty much dealing with a carcinoma. So it's 7 positive, that doesn't really help. 7 positive can be just about anything. Here's CK20. CK20 I'm finding less and less useful as I get older, honestly, unless it's strongly positive and 7 is negative, and that would be, more like GI or Merkel cell carcinoma if it looks neuroendocrine. Because CK20, even these tumors that are supposed to be CK20 negative are almost always have like focal areas of CK20. Now, maybe that's based on the antibody that's at a lab, but I've been at several different labs and it always feels like that staining pattern is like that. This is CK20 focally positive. It's predominantly negative, but it's focally positive in some of these tumor cells. In the past, I think when I first got out of residency, I would have kind of just called this negative. And then I've been to a lot of conferences where I've looked, these interactive conferences where the attendings kind of sit with you, a bunch of people, and they show these stains and there's this tumor that's supposed to be positive for a particular marker, and then they show a stain like this and they say, see, look, it's positive. I'm like, Jesus, I would have called that negative. It's basically negative, but it's focally positive. And so I don't really know what to do with that staining pattern, honestly. Here's PAX8. So PAX8 is predominantly negative. And, it's a nuclear stain, and I don't even see any blush of a nuclear stain. So that would be unusual if this is GYN for it to be PAX8 negative. Also, the other thing, PAX8, kind of takes out a lot of the renal origin carcinomas that would go to the kidney, which could potentially look like that, especially collecting that carcinoma. Now, here's WT1. I told you I kind of, based on the architecture, not so much the site, but based on the architecture, I was thinking it could be like a serous carcinoma. WT1 is actually positive. Again, it's not that strong. And when you compare it to the control, which you should, it's weaker than the control. Like that's pretty dark, distinct staining. But this is positive. But it's not that strong, so I don't know what to do with it. And in the setting of a PAX8 negative tumor, I'm like, well, it's not GYN. What else could this be? Kind of a micropapillary pattern, CK7 positive. It could be a mesothelioma. Mesothelioma, again, presenting as a mass in the adrenal gland without like ascites or anything to indicate a peritoneal mesothelioma would be kind of unheard of. Now here's TTF1. Most common met to the adrenal gland carcinoma is lung cancer, and here's TTF1. So it's strongly, this is not like the WT1, this is strongly diffusely positive. And then NAPSIN-A, which is a granular cytoplasmic staining, is also strongly diffusely positive. So this is metastatic pulmonary adenocarcinoma. Now, like I said, the adrenal gland is a common site for metastases, lung is one of the more common ones. Actually, adrenal gland, I have been told, and I've read, that it's the number 5 most common site for metastasis. Number 1 is like lymph nodes, and then lung, liver, bone. Those are the top 4 places for metastases to occur. And adrenal gland is actually number 5. So if you're talking about organs, it's number 4 if you take the lymph nodes out. But yeah, adrenal gland is a common site for mets. You should always think about it. It's the second most common tumor in the adrenal gland is a metastasis. Lung is one of the most common. So even though this patient was not a smoker, adenocarcinomas are the carcinomas less likely associated with smoking. They still have a smoking association, a lot of them. But this is a metastatic lung adenocarcinoma. So I just wanted to kind of show it to, show a lot of these patients usually have a history of malignancy. This one did not. at least of that malignancy. So it was unusual in that sense. But as far as metastasis to the adrenal gland, it wasn't that unusual because that's, like I said, a fairly common tumor. So here's another adrenal core biopsy that I got when I was in Las Vegas. And this I thought was just so unusual. And I'll tell you kind of my thought process. So this was an adrenal core biopsy. These look like adrenal cortical cells. You know, they have that kind of microvesicular lipidized cytoplasm. But then you can't even really see the tumor. It's so purple. It kind of has the color, because I'm colorblind, I focus on color. It kind of has the color of a pheo, but it certainly does not have the growth pattern of a pheo. This is infiltrating around these adrenal cortical cells. The tumor is very highly malignant. And then the thing that I noticed about this, that I had been taught in residency, but it's hard to find this in the literature, is that there's tons of neutrophils associated with the tumor. It's not like it's necrotic and then it's just like an inflammatory response. These are, you see these tumor cells that have these prominent nucleoli, kind of amphiphilic, almost basophilic cytoplasm, and then tons of neutrophils within it. And I was told that if you have a tumor that's kind of epithelioid with a lot of neutrophils, here's some necrosis, to think about vascular tumors. So an angiosarcoma is rare in viscera, but adrenal gland is one of the more common sites for it to be. And I've showed you this before in that inguinal core biopsy I had when I was in person a few months ago. This is a really common pattern of angiosarcoma. This is an angiosarcoma. And that's that you get these really atypical cells surrounding fibrin when you look at the periphery. Because a lot of times I think as you get older in pathology, your eye tends to skip over a lot of the pink stuff. You know, when you're younger and new, you kind of look at every single tissue piece on high power, but you know, you kind of skip over what looks like necrotic and go to the viable stuff. But when you have a case like this, you really need to focus on this fibrinoid stuff because that's where it will often give you the hint that it's an angiosarcoma. This happens like in almost every angiosarcoma. So this is a primary angiosarcoma of the adrenal gland. I've actually seen one in like almost every location I've practiced. So although they're supposed to be rare, I feel like you see them clinically, not as infrequently as they suggest. Now here's another one that this is one that I saw when I was in residency. So again, this is an adrenal gland. When you have them, when they spread to the adrenal gland, like from somewhere else, like from the bone or soft tissue, they usually go to the surface. But when angiosarcomas occur in endocrine organs, they usually are within the parenchyma. And this one you can see has that a really classic vascular, you know, vasoformative growth pattern. They're usually, don't freeze up on me. Okay, they're usually are high grade cytologically. Either way, they're considered high grade. You don't grade them. We've talked about that before. Again, look at this infiltrating through the adrenal cortical tissue. And then this is another one where, let's see. So you go to these areas and that looks like that papillary endothelial hyperplasia, like an organizing thrombus. Again, it's all kind of fibrinoid looking with the high grade hyperchromatic cells surrounding the fibrin. That's a classic feature of an angiosarcoma. So that's something else glandular looking to think about that is a MET or even primary in the adrenal gland. Now here is the most common primary adrenal malignancy, and this is an adrenal cortical carcinoma. These are hard. They can be hard. Usually they're hard in one of two ways. Either they're hard because they look malignant, they're clearly malignant, often very eosinophilic. This is in the differential for a MET, like to the liver or something, the very eosinophilic looking tumor. You should think about an adrenal cortical carcinoma. So they're either hard because you don't think of it, or they're hard in the adrenal gland because you're not sure if it's an adenoma versus adrenal cortical carcinoma. So this is one where the nuclei are fairly atypical. They have a lot of cytoplasm. There's less clear cytoplasm. A lot of adrenal-cortical adenomas have clear cytoplasm. These are usually much bigger. They're usually 8 to 10 centimeters. They're usually heavy. If you start seeing necrosis, that is a very good feature of malignancy in the setting of an adrenal cortical neoplasm. If you want to separate this from, like, what could this look like? Hepatocellular carcinoma, renal cell carcinoma. SF1 is a good marker that's, relatively new compared to inhibin, calretinin. SF1 is really good at distinguishing adrenal cortical tumors. Obviously, it doesn't separate benign or malignant. Now, for benign or malignant, there are a bunch of different grading systems, not grading systems, but like classification systems. The Y system was, I think, the first one in the 80s that for each different finding within the tumor, you give it a score of 1 for each thing. And then if you have 3 or more, that correlates with malignancy. However, this is not applicable for oncocytic adrenal cortical tumors. And so they came up with something called the modified Y system. Weiss published this, like, I don't know, 20 years after the first one or so. And they took out basically several of the features and then changed the scoring. So now it's out of a score of 7 instead of 9, and changed to still the same 3 or more. I have used Helsinki's scoring system most recently when I had a core biopsy, and then a subsequent malignant or a subsequent adrenalectomy, because they use Key 67, and Key 67, they say if it's over 5%, then it's probably malignant. And that really helped me on a case, which I'll show you in a second. So this is the scoring system that's used. There's not any one scoring system that's recommended. You're just kind of supposed to use one of them. So this one has necrosis. If you look at the periphery, it doesn't really have capsular invasion. There wasn't vascular invasion. There are not many clear cells, so that's would get a score for that. There was necrosis. There were actually quite a few mites in this when you counted per 50 high power field or 10 millimeters squared. So that was an adrenal cortical carcinoma. This is also one. This, I think this one really looks like HCC, honestly, and that isn't a differential. Again, you could do immunostains. This would be SF1 positive, HepR1 negative, glypican-3 negative. But remember, some hepatoid tumors that are not HCC can also be positive for those hepatocellular markers. Here again, you have this kind of high-grade looking nuclei, really prominent macronuclei. This small cell pattern is something that's kind of talked about, where you get less cytoplasm. That's often a feature of malignancy in some of these, adrenal gland, hepatocellular. A lot of times you're looking for big cells to say, oh, something's malignant. And a lot of times it's the opposite, almost nevoid looking in some areas. This was an adrenal cortical carcinoma. You can, this could also be melanoma would be in the differential, I think, in this. There's intranuclear inclusions. Some have prominent nucleoli, kind of a nested growth pattern. Melanoma is a very common met to the adrenal gland. Again, that should be easy to tell with stains. And then here's the one I was talking about where I had a core biopsy. This is when I was in Austin. And this was actually, I remember them presenting this at tumor board before they had done tissue. They had just done a CT scan, screening CT for something else. I don't think it was a screening. It was for like abdominal pain, but like GI kind of symptoms, diarrhea, et cetera. And they found this like 4 or 5 centimeter adrenal gland mass, and the radiologist, I remember saying, oh, it's kind of suspicious looking, whatever. It's not that big. It's in the adrenal gland. It's kind of an incidentaloma, so I figured it was going to be benign, and they did a core biopsy, and I knew the history, and so I was kind of less suspicious. But on the core biopsy, they basically got an area that looked like this, that looks like kind of a widely invasive follicular carcinoma, the way that's growth pattern, these multiple nodules separated by fibrous strands. That's really suspicious for adrenal cortical carcinoma. And the nuclei aren't that bland, but they're not like markedly atypical. but I could not find mites on the core. I could not find necrosis. But that architecture was odd, but that architecture isn't part of the modified Weiss system. And this is kind of an oncocytic tumor, so you can't really use the Weiss system. So I got a Ki-67 and it was like 15%, which is much higher than the 5% cutoff. So I suggested that this is likely an adrenal cortical carcinoma, and then they took it out and it's clearly adrenal cortical carcinoma. There are areas of necrosis here. The growth pattern is just not consistent with anything benign. Here's some necrosis that was, not biopsy site change. Remember, they had a biopsy. You have to be careful of that. So anyway, so this is kind of one of the blander adrenal cortical carcinomas where Ki-67 for me on the core biopsy was very helpful. Okay, one last case, and it's case number 1. This is a case that I didn't see when it was worked up. This was a case in Austin where several good pathologists in our group had looked at this case. It's an adrenal gland. This tumor is within the adrenal gland. Here's the outside of the adrenal gland cortex, and then here's this tumor. Kind of a solid nested pattern, some lymphocytes. Kind of oval to round nuclei, hypochromatic, bland chromatin pattern, not coarse, no mitotic activity, very rare mitoses, no glands. This could be adrenal cortical. If it is this a carcinoma? It's kind of solid, but it's not mitotically active. There's some lymphocytes intermixed. It's somewhat vascular in areas. Here it's kind of falling apart, which I think when you look at it closer is vascular. Always think about renal cell, something like this. This doesn't really look like a renal cell. It could be. Here's some more of that vasculature with the separated cells in between. So they had no idea what this was. They did a bunch of immunostains. It stained for really nothing. No keratins, nothing, no renal markers, inhibin. We didn't have SF1 at the time. I don't even think it was really used when this was done. Calretin negative, everything was negative. So they sent it off to Memorial Sloan Kettering. They're like, we don't know if this is benign or malignant. I think I've told you before, there was a really good neuropathologist that I trained under in Mass General, and she used to always say, if you don't know what something is, you don't know whether it's really benign or malignant. I think that that's for the most part true, but it's kind of good advice. They didn't know what it was. They didn't know if it was benign or malignant. Sent to Memorial Sloan Kettering, a lot of really good, well-known pathologists there looked at it, had no idea what it was. They ended up saying it's probably a carcinoma. It's probably a MET, just based on kind of epidemiology. So an oncologist in Austin decided to send it for, at the time it was called, the tissue of unknown origin or cancer type ID, which is what it is now through Hologic, where they take the tumor block, do molecular testing and see what it kind of matches up with molecularly. And that's how I got the case, because I was rotating at the hospital where this was removed from. And I was the pathologist of the day where you sign out addendums for cases that are pathologists that aren't there rotating there at the day. So I got this tissue of origin study result. And a lot of times we used to kind of make fun of them because they were so off in the very beginning. Some of them were right on, but a lot of them were like, so off. This came back meningioma. And I looked at it, the report, I like meningioma of the adrenal gland, and I had never seen the slide. And so before I went and got the slides, I did like a PubMed search, and I saw that a meningioma of the adrenal gland has been described. And then I pulled the case, and I was like, oh my God, this is a meningioma of the adrenal gland. That's exactly what this is. Look, there's a mite. This is an atypical meningioma primary in the adrenal gland. It's just almost unheard of, but it's not unheard of. It does occur. So there was, when I had done the search, there was this, that wasn't even an article. It's a letter in Pathology from 2007 talking about incidental meningioma of the adrenal gland. Now, you can get metastatic meningiomas. Those are not that common. But this is a primary meningioma. Usually primary meningiomas outside of the CNS or in the head and neck area. This is obviously nowhere near head and neck. So just thought it was kind of an unusual case, but it's funny when you hear meningioma, or if you saw this and they said it was a dural mass, you wouldn't think twice. You'd know that this is a meningioma. It's just kind of that context. If you see someone, you see someone at a checker at the grocery store all the time, and it's easy to identify them, and then you're on vacation somewhere and you see that person in a restaurant, you're like, I know that face, but I don't know where. But anyway, it's kind of the same thing. I kind of a funny story about that. I am not like that. I have good facial recognition skills, which I think helps me as a pathologist. But I'll tell you a quick funny story. When I was in residency, I used to get lunch every day at the cafeteria at MGH, and I always went to the sandwich counter, and I had them make me a half turkey, half roast beef sandwich with provolone cheese every single time. And there were only like 3 women that worked behind the counter, and they would see me coming and they would start making my sandwich because it was so weird. They would always say, you don't want anything else on it? No lettuce, no tomato, no mayo, no mustard. I'm like, no, plain, half turkey, half roast beef, provolone cheese on top. So then I got that almost every day for like 5 years. And then my first job was in Vegas. About 6 months into my job in Vegas, I went gambling at a local casino with a friend of mine, and he, I think, gambled quite a bit because he had free buffet tickets. And so we went to the buffet afterwards. We had like dinner, and then he said, oh, you should really check out the dessert bar. It's really cool. And so there was this like big glass case, like a circular glass case with the workers inside, and you just I walked around the glass case like, a shark, kind of looking for my prey because I love dessert. And I finally kind of decided what I wanted, and I looked up, and the woman behind the counter was the same woman that used to help me and make my sandwiches at the Mass General cafeteria. And I immediately recognized her. I said, oh my God. I said, you're from MGH. I said, you were in the cafeteria. I said, I'm the resident that always used to get the turkey and roast beef sandwiches with provolone. And she just looked at me like dead face and said, yeah, I work here now. I was like, okay, I guess she didn't like me. She didn't like my sandwich order. So anyway, but I recognized her right away, even though it was a different context. So let's move on to case 2. Oh, the other thing I didn't mention, adrenocortical carcinomas are often associated, especially in kids, with germline mutations. There's a lot of germline mutations, but one of the more common ones is Lee-Fraumeni. So if you have a kid with adrenocortical carcinoma, it's not infrequently Lee-Fraumeni, but you can get it with NF1, Lynch, FAP, Beckwith-Wiedemann. So anyway, the second case, 65-year-old man, UC, known stage 4 malignancy. Endoscopy showed a mass in the gastric fundus that was biopsied. So okay. Oh, by the way, Ben, I see you're on. Make sure you tell your lovely wife happy birthday from me. So this is epithelioid spindled in like the base of this mucosa, normal gastric mucosa, kind of has a reactive gastropathy appearance, this corkscrew, but clearly what's going on is what's underneath here. So it does not look like it's involving the surface mucosa, or I mean it is, but it's not mucosal based, I should say. So epithelioid to spindled malignancy in the stomach. I think GIST is reasonable in the differential. Also metastases, melanoma, neuroendocrine tumors. This kind of, if this was in the thyroid, you think, oh, it's a medullary carcinoma. So anyway, now this person actually had a history, I told you. But let's say you're thinking it's a GIST. Let's say they don't have a history. This is CD117. This is strongly positive. This isn't just like patchy weak like that CK20 and that long adenocarcinoma. Every single like fragment of the tumor is strongly diffusely positive. So maybe it's a GIST. So then you get dog 1. Dog 1 is not. Dog 1 is totally negative in this case. You know, there's some like vascular staining or something. Or I don't know what that is actually. But it looks nonspecific. The tumor is actually negative. So now this person had actually a history of melanoma. And here's the SOX10. So strongly positive. The point of this case is that melanoma is not infrequently CD117 positive, and it can be strong. I had a case where a colleague in Austin showed me an anorectal lesion that was very spindled, and she thought spindle cell, GI tract, GIST, did CD117, SMA, whatever, CD117 was strongly positive. And she showed it to me as agree with GIST. The problem with that is that GISTs are unheard of in like anorectal, and melanoma is not, especially in elderly patients. And so I said, and I know about this pitfall. So I said, now I think this is a melanoma. She did S100 and melanA, strongly positive. So that's a very easy pitfall in the GI tract. Here's melanA in this case. So this is metastatic melanoma. You know, melanoma is very common to metastasize to the GI tract, more often small intestine, but stomach is also up there. Let's see, this was the core biopsy where I had made the diagnosis. Now, the interesting thing about this is a long biopsy. This is the same patient. The patient did not have a history of melanoma when I got this. In fact, the radiation oncologist called me before I got the biopsy and said, hey, this person has a large lung mass and multiple brain mets. And I just need to know what kind of carcinoma it is, because I need to know if it's small cell versus non-small cell, so I know how to treat the brain mets. And the person's not doing well. I said, oh, okay. So when I got this, I had been, biased. And so I was like, God, what kind of carcinoma is this? It kind of is small cell, like looking sort of neuroendocrine, not much cytoplasm, but then it has an architecture that's kind of like almost fully differentiated or basaloid squamous cell. So I called him and I said, yeah, the radiologist got the biopsy, they got the tumor. I said, I think it might be like a squame, maybe neuroendocrine carcinoma. I said, I don't know. I'm going to have to do immunostains. So then I did P40. Obviously, it's P40 dead negative. That's the differential for squamous cell versus small cell, which is not infrequent as a differential. P40 TTF1. TTF1 was negative. TTF1 is positive in 90% of small cells. P40 is positive in almost 100% of squamous, not completely. I did neuroendocrine markers, which you don't have to. Those were negative. I did CAM 5.2 after that, because I do that for small cell just to get a positive, because small cell is more often positive for low molecular weight cytokeratins, which is CAM 5.2 is one of them, negative. So then I went back, looked at the H&E. I'm like, let me look at this again. What the hell is this? And the thing that tipped me off was not the morphology, but I was thinking, what else would give you multiple brain mets? And I thought, melanoma does that. And then I looked at this again. I'm like, oh my gosh, I think this is melanoma. So then that's when I went back and did SOX10. SOX10 was strongly positive. melanA was strongly positive. Here's melanA. So this is melanoma. And they didn't believe it. They said, well, is it primary? I'm like, I don't think you get primary melanoma of the lung. He probably just had a melanoma somewhere else that he either was missed by the pathologist or called something else, especially because of the morphology of it, or it regressed. That happens as well. So anyway, thought that was interesting. That was the same patient. Now, this is another case that I got not long ago where the patient had no history. It's a small bowel resection for small bowel obstruction. and they went in and found a mass. Now, normally when you find a mass kind of outside small bowel that's causing obstruction, the more common lesion that you're going to find is a gist. When I cut it open, like it was ulcerated. It wasn't like a solid mass like most gists are. Most gists in the small intestine aren't going to be so high grade necrotic looking. You can get that, but that's weird, grossly. And then this is what I thought was so interesting is the wall was very thickened. It wasn't really forming a distinct mass. It was just kind of expanding the wall. When I see that in the GI tract, I always think of lymphoma. So I saw the surgeon who removed this kind of in the doctor's dining room break area right after I grossed it, and I said, "Hey, that person doesn't have a history, does he?" And he said, "No, I don't know what this is." And he said, "I think it's a gist." I'm like, "I just cut it. I don't think it's a gist." I think it might be a lymphoma. I said, "Hopefully for him, that's what it is." And then I got the actual sections, and you can see it's expanding this mucosa. Like here's the mucosa and the wall, and then it's just kind of expanding that, thickening the whole wall. And then when you look at it, this is really ugly. If this is a lymphoma, it's going to be like an anaplastic large cell lymphoma. But with this morphology, this looks like melanoma. Very almost rhabdoid looking, lots of mitotic figures, really prominent macronucleoli, pleomorphism. The other thing in cytology for melanoma is like on FNAs, one of the things they talk about are mirror cells, which is where you have like a binucleated cell that looks like it has like a mirror image of the nucleus, like on either side, kind of like this, almost like a Reed-Sternberg cell. That's something. Oh, look at that tripolar mite. That's something that is not specific. You can see that with plasmacytic things as well. But that's something that's not infrequent in melanomas, to see these binucleated cells that look like mirrors, a mirror image of it. So this one, that case was a melanoma, just to show you the CD117, and that one was actually also positive, but more the positivity you would expect with a non-gist. It's actually kind of weak, focal, but S100, SOX10, MELAN-A were all strongly positive. Here's just to show you the MELAN-A. So this was metastatic melanoma. The person did not have a history. Now, the differential in the GI tract, especially the small intestine with a melanoma, is this tumor that's primary. It's more often in men, usually younger men, almost always small intestine. It often has this growth pattern that looks like endometrial stromal sarcoma. That's what I think. I think this looks really like a uterus with low-grade ESS. And when you see that pattern, you should think of malignant gastrointestinal neuroectodermal tumor or clear cell sarcoma of the GI tract. Here it seems a little more clear. These are very difficult to tell from some melanomas. The genettes are less atypical than most melanomas. They don't stain positively for MELAN-A a lot of times. So the clear cell sarcoma of the GI tract, some people will call it that if it stains for the melanocytic markers like MELAN-A, HMB45, etc. And if it doesn't, they'll call it a malignant gastrointestinal neuroectodermal tumor. They're probably a spectrum of the same lesion. They all have EWSR1 mutations, and that's how you really tell them from melanomas. Is you should probably do molecular testing in these. I've only had 3 of them in my career. Who knows if I missed another one? But I've done the mutation, all of them, because sometimes it's very difficult to tell from melanoma, because they can look like a melanoma. Here's one that I had that I've showed you guys already, where we had the biopsy because they had done a biopsy, because they often present like primary lesions, not like a met, and they often have lymph node metastases. That would also be regional lymph node metastases, would be kind of weird for a melanoma, a metastatic melanoma. You can get it, but I think having a presentation of like a primary colon tumor with regional lymph nodes is more typical of these clear cell sarcomas of the GI tract. Again, very ESS looking, not very atypical, kind of a vaguely clear cytoplasm. The growth pattern is typical. Again, they're more often in the small intestine. It's uncommon to find them anywhere else. This one was actually colon, which was unusual about it. That's why when we had the biopsy, even though it was negative for HMB45 and melanA, a lot of metastatic melanomas are. So we actually favored melanoma on the biopsy, but did know that that could be in the differential of a GNet. Okay, what's this? Okay, so this is another something you often find in the stomach that can give you a lot of trouble on biopsies, even on resections. So this is very epithelioid looking, very myxoid looking stroma. But then here it kind of has like a pecoma look. That's the feeling I get with these. I feel like they look like pecomas. And then you start seeing like multinucleate cells, rhabdoid looking cells. So when you have that in a stomach, kind of a solid epithelioid to focally spindled growth pattern with myxoid stroma, here it's getting a little more spindled, myxoid stroma, rhabdoid multinucleate giant cells, or multinucleate cells, I should say. This is probably a PDGFR mutated GIST, and that's what this is. Here it looks a little more gisty, a little more epithelioid to spindle. They often have a mixture. These are most often in the stomach. They are kind of very benign behaving. The problem with these is they're often CD117 negative or really weak. So then they don't really look like the typical spindle cell GIST. So if you're not thinking about it and you do CD117 and you don't, so let's say you don't have DOG1 or you don't do DOG1 or whatever, because DOG1 is more often positive in these, you're going to miss these. And they do not respond to the typical imatinib, like the c-KIT mutated ones. Here's one that I actually was shown in Austin by a colleague who showed this to me and said, hey, you agree this is a signet ring cell, like diffuse type stomach cancer. This was a biopsy in a person with an ulcerated stomach mass. So you can see there's a little hemorrhagic, ischemic looking gastric mucosa. And then you have this kind of myxoid, epithelioid single cell. This looks like it's either a diffuse type gastric carcinoma or what else? Lobular carcinoma. Lobular carcinoma, which often goes to the stomach, really looks like this. But the myxoid stroma, to me, I thought it was myxoid, not desmoplastic. And then this was, to me, the tip-off when he showed me this case, is this looked a little more spindled. And I'm like, I bet this is a GIST. This is a PDGFR mutated GIST. And that's exactly what it was. This, I mean, you call this signet ring cell carcinoma, that's a bad mistake if this is essentially a benign form of a GIST. So you really have to keep that in your differential when you've got these epithelioid tumors in the stomach. And then here's another stomach tumor. This is another GIST. These are usually in kids, more often in girls. They typically show vascular invasion. Look at the vascular invasion with this. They have this multinodular growth pattern, and they're more often epithelioid, kind of also kind of rhabdoid, abundant eosinophilic cytoplasm. This doesn't look like a GIST, but this is an SDH deficient or mutated GIST. So this would be, these are CD117 DOG1 strongly positive, but then they would be negative for STHB if you think to do that. Usually, more often these are in kids, they're almost exclusively in the stomach. So again, knowing that epidemiology, knowing even if the morphology is unusual for a GIST, knowing that a lot of epithelioid GISTs occur and they're often not CD117, that's a helpful thing. And then there are areas, this is that same case, where it does look more spindled. So hopefully you have areas, if you don't know the epidemiology very well, that you have areas like this to make you at least think of GIST because it's spindled. And then speaking of not knowing not getting the idea of a tumor because it's in a weird location. This kind of falls into this one. This is another stomach tumor that happens. It's often misdiagnosed as usually an endocrine tumor because they're very bland. There's a lot of vascularity, very round, almost looks kind of salt and pepper chromatin pattern, very vascular, very bland, very little mitotic activity. They often have this, staghorn-like vascular pattern, HPC, hemangiopericytoma-like vascular pattern. But then if you look at these areas, and if this was a painful lesion under the fingernail, you'd say, oh, well, it's a glomus tumor. This is classic glomus. This is a glomus tumor of the stomach. They occur in the stomach. So you have to know they occur because they are not infrequently misdiagnosed as endocrine tumors, and they can be synaptophysin positive. So that can cause a problem. These are typically benign. You can have malignant ones, but they're typically benign. But just to keep that in your differential for epithelioid-looking tumors in the GI tract. And then one more thing to keep in mind, this is a small intestinal biopsy. It was a core biopsy done of a small intestinal mass in a youngish woman. So when you have a young woman with a mass in her abdomen, you invariably are going to think about GYN tract stuff, serous borderline tumor, serous carcinoma, etc. And I think that could look like this, kind of a papillary appearance. Something I talked about last time is when you see in cell blocks of like an ascites, when you see these papillary cores with like a myxoid mucopolysaccharide kind of matrix within the center. Look at that. They're not ringlets. These have solid centers. Think about mesothelioma. This is a mesothelioma of the perineum. They're not infrequently in younger patients. They typically do better, much better than pleural mesotheliomas, like several times better, like they survive several years, whereas pleural is basically a year. So keep this in mind in your differential for a papillary looking tumor that's on the outside of the GI tract. All right. Oh man, doing too well on time. All right, case 3. 16-year-old woman, flank pain, hematuria for 2 months. CT scan of the abdomen pelvis revealed a large left kidney mass. So they did a CT guided biopsy. So this looks malignant. You would expect it to be malignant. It does not look like a typical renal cell. This looks glandular. You can get glandular looking renal cells, but usually that would be like a collecting duct carcinoma. I think collecting duct carcinoma would be high up in the differential with a case like this. They're rare. They're like less than 1% of renal tumors. But still, that would have this kind of high-grade nuclei. I think also GYN tract in a woman, same thing, because this, I think, again, looks like that kind of micropapillary appearance. Like it could be, like you could take a picture of that of an ovarian tumor that's a serous carcinoma, no one would second guess you. So, got to do immunostains in the case like this. This patient had no history. Again, let's start with the CK7, strongly positive. That doesn't narrow anything down if you're thinking collecting duct carcinoma. What does help a little bit is this is PAX8. Because, it's presenting like a primary kidney tumor. So I think the differential would be a urothelial carcinoma of the renal pelvis with extensive glandular differentiation, although this is pretty ugly for that, versus a collecting duct carcinoma. So PAX8 has positivity, but it's not in the nuclei. So this is negative for PAX8. So don't call this positive. They're frequently messy with cytoplasmic staining. So this is negative. Most collecting duct carcinomas are positive. So then you got to think about, like I said, urothelial carcinoma. So this is P63 because they can have prominent glandular differentiation. Differentiation is totally negative. So now what? Is this a MET? You can get METs in the kidney. Here's TTF1. TTF1 is off the charts positive. And then here's napsin A. Also positive in that granular cytoplasm. So this is metastatic pulmonary adenocarcinoma presenting as a primary kidney mass. This is really, really rare. Less than 1% of kidney tumors are metastases. 90% of metastases to the kidney have a history of malignancy. This one did not. So this is a rare tumor, and it has a rare presentation because the patient did not have any known lung tumor. And so they scanned the chest after this and found a upper lobe lung adenocarcinoma. So again, very, very weird, rare presentation, but you kind of just have to go through the motions to figure out what this is. So this is actually a collecting duct carcinoma. I talked about how vascular tumors, especially epithelial angiosarcomas, can have a lot of neutrophils. So can collecting duct carcinomas. That's the other thing that should kind of tip you off, is to find neutrophils in the setting of a malignancy in the kidney. You want to think about collecting duct carcinoma. These are usually high grade. They often have a tubulopapillary appearance. This one is a little more solid. They often infiltrate deceptively into the kidney parenchyma, whereas renal cells don't typically do that. Here you have the medulla, and you have the tumor kind of infiltrating. The things that do that are collecting duct carcinomas and urothelial carcinoma. So that should be in your differential when you see that growth pattern. But if you see something like this looks like it could be a renal cell carcinoma. But then you really have to look more around. Look, it's very glandular. Interestingly, a lot of collecting duct carcinomas that were called collecting duct carcinomas in the past have now been found to be FH deficient renal cell carcinomas. It's like 25%. Collecting duct carcinomas are really rare. I've only seen a few of them, and here's one that unfortunately it's completely faded. But this is why I think a lot of them have been called collecting duct carcinomas that are FH deficient, is because they often have this papillary growth pattern with really high grade nuclei. That like inclusion-like nuclei, it's like an inclusion. This was a PIP case from years ago, so maybe they were wrong. Maybe this is actually FH deficient, but this was categorized as a collecting duct carcinoma. You have that, again, that kind of cribriform looking tubulopapillary appearance. That's what is typical for collecting duct carcinomas. Let's see. Here is the other case that I was mentioning that would be in the differential that infiltrates into the kidney. So here you have some tumor. It kind of looks like it could be glandular. It looks like there's spaces. It's more acantholytic looking. Again, very high grade. Look, that looks like that could be glands. And again, infiltrating into the renal tubules. So you'd be seeing that, and you'd think, oh, well, maybe this is a collecting duct carcinoma. But then you see the squamous differentiation, and it looks a little more transitional here. So this is actually a pelvic urothelial carcinoma. So these are one of the most frequent tumors seen in the setting of Lynch. It's more often MSH2. But when you think about urothelial carcinomas, it's you definitely want to think about Lynch. At least mention it here. See how it's infiltrating around the glomerulus? This is a classic growth pattern when you have a core biopsy of a kidney and they happen to get some benign renal elements. Immediately put renal cell carcinoma much lower on your differential when you see that pattern. Oh yeah, this is the other thing when you see tubules. So this is a relatively new, over the last 2 WHOs, I think, classification of a renal cell carcinoma that's usually well defined, has these long tubules, low cuboidal cells that are very bland, and then you'll see that's kind of myxoid mucinous kind of stroma, and then there'll be areas where it might, here's some more of that like bluish stroma, and then you'll have areas where it kind of transitions into slightly more spindled areas. Again, long and anastomosing tubules, low cuboidal cells, bland morphology. This is a mucinous and spindle cell carcinoma of mucinous tubular and spindle carcinoma of the kidney. They can often have these little papillary protrusions and sometimes can have foamy macrophages. So the differential would definitely be with a papillary renal cell. But, look for the varied appearance, that kind of basophilic mucopolysaccharide kind of material, extracellular material to make that diagnosis. These are pretty bland behaving. All right, last case. So this is a 74-year-old woman, history of breast cancer 30 years ago, had surgery and chemo, presented to the ED with right hip and back pain for 1.5 months, found to have a lytic lesion involving the right ischium, so they did a CT guided core biopsy. So this isn't that diagnostic of a dilemma. It's just to talk about kind of management of these. This looks like reactive remodeled bone. It doesn't look like typical just lamellar, well-formed bone. It's kind of woven looking. It looks like this has kind of been injured. And then you find these areas where it looks like there's this fibrous stroma. And it looks crushed, but it kind of looks like there's something in here. Her history of breast cancer was 30 years ago. That would be weird for it to be metastatic breast, but it absolutely is possible. And so when you have a case like this, where it's an adult with a lytic bone lesion and you see stroma that looks a little reactive, especially in this case, this looks like an intracytoplasmic lumina. No title. These look like single cells, maybe like forming a little nest, tumor cells here. You should get a keratin stain. Now, I am not one of these people that likes to just screen with stains. I know there are lots of people that do that. I'm not a fan of that practice pattern. This was the other biopsy. There's this kind of hanging out. It's kind of in the middle of nowhere. That could be a floater. You don't really know. But this looks like that's not a floater. And it looks like there's some single cells in here. Now, if this is breast cancer, it's probably ER positive because most of the carcinomas from the breast that go to the bone are ER positive. But let's start with a keratin stain and see if you get anything. So here's the keratin. Now, the reason I don't like to screen with keratins, like I knew a lot of pathologists that if they have a bone biopsy like this, automatically get keratins. I don't do that. I'll get levels if I don't see anything, but I don't just do a keratin if there's like nothing where it looks like there could even possibly be tumor. If it was just all bone with no reactive like fibrous stroma, I would not just get a screening keratin. Other people would disagree with me, but I'm not a fan of these like automatically do this, do things without thinking. You know, there was a PA from my first group in Vegas, who she used to say her motto, she told me her, like I came into the gross room and they were doing a frozen on an ovary and I was assigned to it. And the PA had put ink all over the ovary. And I said, why did you ink this smooth surfaced ovary? And now there's like ink all over it. I mean, it looked like someone spilled a tube of ink like all over. And the PA manager, whose name was Lindsay, spelled Lindsay, like Lindsay, but it's pronounced Lindsay. When I first met her, she corrected me, and I said, "Oh, I'm sorry. I thought it was spelled Lindsay," and she said, "No, it's pronounced exactly as it's spelled, Lindsay." So I said, "Oh, isn't that how people spell Lindsay?" Oh, she said, "Yes, but it's pronounced Lindsay." I felt like saying, okay, well, I guess you can call me Paul because that's how my name is spelled also. So anyway, so their motto was ink, don't think. And I told her, I don't think there's any motto that's a good motto if don't think is in your motto. That's not a good policy. So I don't like to just do keratins, but in a case like this, I did for this reason, and it's positive. Here is GATA3. Again, it's positive. You see now it's kind of highlighting that kind of small tubular appearance. I mentioned that these are usually ER positive when they go to the bone, whereas like here's ER, so you can see it's positive. It highlights it well. Whereas tumor, like breast tumors that go to the brain are either triple negative or HER2 positive typically. So like ER positive, PR negative breast tumors typically don't go to the brain. They can. If anything, they'll go to the skull more than the brain parenchyma. But, it's interesting how these different tumors go that from the same anatomic site based on their biology will spread differently. And it's known, so that should keep that in mind. So the common tumors that go to bone, there's 5. Breast was one of them. So there's different mnemonics: BLT with kosher pickles, so B, breast; L, lung; T, thyroid; K, kidney; P, prostate. So this is the T. This is thyroid. This is follicular carcinoma. This was like an oncocytic carcinoma that went to the bone. More often the bone kind of in the upper body, head and neck area, but it can go anywhere. If you don't have that history, I think this would be hard. And again, this would be TTF1 positive. So if you don't think to do like Pax8 or Napsin or something to say that it's thyroid or thyroglobulin, I think you could easily. Well, I think we tend to forget about thyroid as being an aggressive tumor. This is the K. So this is kidney. Now, kidney in the bone, usually there's a history, but I am telling you, you better be careful with these because it's very easy to miss, because most of these are clear cell. A lot of clear cells are just hemorrhagic, and it looks like there's fibrin. So it's one of those things like angiosarcoma. You're at low power, and you're like, oh, that's just a lot of blood. That's just a lot of fibrin. Let me show you. Like this, at low power, you're like, oh, well, that's just blood. But then if you actually look closer, there are lots of tumor cells in here. But at low power, it just looks like fibrin. And that's a common thing that you see with renal cell, specifically in the bone. So keep that in mind. This is one that I've seen a bunch, and it's not in the top 5 for going to bone, but it is one. So this is hepatocellular. I've seen a bunch of hepatocellular carcinomas be in the bone. This is one where they have a history. So here's the fragments of bone, and it has this very poorly differentiated HCC pattern, but it does have that sinusoidal wrapping that you see in cytology and in histology. But again, I think if you just had this without a history, the architecture should make you suspicious. And the fact that it's in the bone and that hepatocellular carcinoma is a common carcinoma to go to the bone. Pancreas is the other. If you were to make it 7 instead of 5, it would be BLT, KP, and then liver and pancreas. Those are the number 6 and number 7 to go to bone. So this is HCC. Let me show you one more, a kid. So in adults, if they have a bone tumor, it's most often a malignant bone tumor in an adult is most often a MET. A malignant bone tumor in a child is most often primary bone, like osteosarcoma. But this is an example of a kid that had a medulloblastoma that then spread throughout their body and went to the bone, spread extra CNS. And so, small blue cell tumor in a kid, this could be small cell osteosarcoma, but medulloblastoma, neuroblastoma would be in the differential. So that's just, in a child, this I just thought was an interesting case. It looks just like a small blue cell tumor, give you the whole differential, working that up. One other thing to keep in mind, I mentioned adults with epithelium or something malignant in the bone is usually a MET. This is the example to keep in mind when it is not. So this kind of almost looks like a mieloblastoma, whereas that kind of reticulum look, almost squamoid appearance, merging with this stroma. So this is a primary biphasic tumor of the bone called adamantinoma. You have classic type and you have the osteofibrous dysplasia-like type. So this has too much epithelium to be the osteofibrous dysplasia-like type, which are more often in kids. These can occur in any age. I would say median is like 25 to 35. And so you have a bone tumor, and these are almost always tibia, like 85 to 90% arise in the tibia, specifically the anterior tibia. So if you have something like that in a 30-year-old, MET would be weird. Like what METs would look like this and would a 30-year-old get? So you should keep that in your mind. Again, tibia. For METs, they can go anywhere in the bone. They're usually long bone, a lot of spine, and they're not infrequently in the metaphysis of the bone because that's the more vascular part of the bone. And so just like, tumors that spread in a vascular pattern are going to go to things that are vascular, and the metaphysis is the most vascular part. So again, this is an adamantinoma. These recur often, and they can kind of undergo high-grade transformation. But the primary ones before they do that are kind of bland looking. Again, they have this kind of fibrous dysplasia look, even when they're not the osteofibrous dysplasia-like. And then they have these, varying numbers of nests of this epithelium. So adamantinoma. You don't see these very often. I've only had a couple. All right, 903, not bad. Any questions for me? Nada? All right, I guess then that's it. My next one is January 17th, I think. And if you don't have any questions, I guess I'll let you guys go. All right. Well,
Thank you.
Yeah, you're welcome.
Thanks so much.
Merry Christmas.
Thank you.
All right. See you guys later.
Hey, Paul.
Hey, are you at home?
Yeah, I'm working from
Oh,
home.
tell Emily happy birthday.
Yeah, she heard you.
Okay, good.
Right, and I told her. She also made an exception for Ruben. He doesn't normally get screen time, but she let him watch a little bit of
Oh,
histology.
he's so young. Does screen time matter this young?
They say nothing before like 2 or what, I don't know.
Really?
Or
Oh.
1 or something.
Well,
I don't
this
know.
is different. This is educational.
Yeah, I was making sure he caught all the finer points. So
Well, have a Merry Christmas.
yeah, you too.
All right, I'll talk to you later.
Okay, bye, Paul.
Bye.